Hi, my name is Mohamed Saleh Ismail, and for September Journal Club, we will be discussing an article by Hu and colleagues entitled Combination Therapy Does Not Improve Rate of Clinical or Endoscopic Remission in Patients with Inflammatory Bowel Diseases Treated with Vedolizumab or Ustekinumab, published in Clinical Gastroenterology and Hepatology, July 2020. Loss of response is a significant issue with the implementation of different biologic therapies, and is expected to occur between 10 to 25% annually. Immunogenicity is an important mechanism for loss of response. Previous literature has demonstrated higher clinical and endoscopic remission rates in combination therapy of infliximab and azathioprine compared to infliximab monotherapy. In contrast, little is known about the impact of such combination therapy with the newer biologic agents, including vedolizumab and ustekinumab. The primary aim of the study was to evaluate the impact of concomitant immunomodulatory therapy on clinical and endoscopic outcomes for both vedolizumab and ustekinumab treated patients. Clinical remission was defined as Harvey-Bradshaw index equals or less than 4 for Crohn's disease, or simple clinical colitis activity index or Mayo score less than 3 for ulcerative colitis. Clinical response was a decrease of Harvey-Bradshaw index by 3 or more from baseline for Crohn's disease, or simple clinical colitis activity index or Mayo score of 2 or more from baseline for ulcerative colitis. There was no difference in clinical response or endoscopic remission for combination therapy versus monotherapy in both vedolizumab and ustekinumab groups. Also, baseline immunomodulatory use was not a predictor of clinical response or endoscopic remission in both vedolizumab and ustekinumab groups in multivariable analysis. These Kaplan-Meier curves show no impact of combination therapy on durability of vedolizumab or ustekinumab in both groups. Study strengths included 1. Large sample size. 2. Combination of patients from tertiary centers in 3 different countries. 3. Implementation of propensity score adjustments in the multivariable model to account for the non-random allocation to the combination therapy arm. Several limitations preclude the generalizability of these results. 1. Selection bias was found, as patients selected for combination therapy may have more severe disease phenotype. 2. The majority of patients were biologic experienced. 3. Objective measures such as fecal calprotectin, C-reactive protein, and drug levels could not be analyzed, as not all centers performed these tests during the 1-year follow-up period. 4. No data were available on immunomodulator naive states to examine whether the benefit was greater in those who were immunomodulator naive at initiation of combination therapy. 5. Study sites did not systematically collect information on serious infection or other safety endpoints. In conclusion, combining vedolizumab or ustekinumab with an immunomodulator was not associated with improved clinical or endoscopic remission or response in the first year. Thank you for your attention.